Next question. A 61-year-old woman with altered mental status is brought to an urgent care clinic by her husband. The patient's husband says that her symptoms began acutely 24 hours ago. He says that she suddenly started to feel excessively drowsy and her mental status rapidly became altered. Her past medical history is significant for a renal transplant 18 months ago, which is well managed with immunosuppressive medication. The vitals include a temperature of 103 degrees Fahrenheit, blood pressure of 85/50, pulse of 135, respirations are 24. So she seems to be in a state of sepsis. On physical exam, the patient is arousable but unresponsive to commands. The patient is not oriented to time, place, or person. Her GCS score is 10/15. Multiple black skin lesions are present on the trunk. Lesions are approximately 4 centimeter in diameter and round with a necrotic center forming an eschar. Lab findings are significant for a hemoglobin of 14.2, WBC 3,700, neutrophils are low, 22%, lymphocytes 52%, monocytes 17%, eosinophils 5%, basophils 4%, platelets 1,79,000 and BUN of 15. Creatinine 0.8, cultures are positive for Pseudomonas. Which of the following factors is most likely to be responsible for the patient's condition? So is it failure of TMP-SMS prophylaxis therapy, failure of immunosuppressive therapy, decreased IL-2 levels, DiGeorge syndrome, or a decrease in the phagocyte cell count? Yeah, this was a good one. So this was a diagnosis of Pseudomonas aeruginosa, which they gave away to us. The skin lesion they were talking about is typical of Pseudomonas. So now let's see why this infection was caused. Okay, so this patient is presenting with septic shock, which we did recognize based on the vitals here. He's got elevated temperature of 103, his blood pressure is low, pulse rate is high, respiratory rate above 21 would indicate that, and also his mental status is altered. So all of them suggesting septic shock as indicated by the decreased BP, increased temperature, pulse, respiratory rate, decreased WBC count. Yep, her WBC count was 3,700, so that was below the normal range, and presence of Pseudomonas. The factor that predominantly contributed to the infection is most likely the neutropenia caused by immunosuppressive medication she's taking for the transplant. A decrease in the neutrophil count results in a decrease in phagocytosis and increased vulnerability to infections, especially the bacterial infection. So now let's just talk a little bit about what this organism is. It is aerobic, it is gram-negative, it's a rod, it is oxidase positive. It's important to remember the oxidase positive organisms. It kind of helps answer questions sometimes when you don't know what's really happening. It causes severe infection in neutropenic patients and in burn patients. So those would be two risk factors for a Pseudomonas infection, which are high yield to remember: neutropenia and burns patients. Okay, these are ones which are susceptible to Pseudomonas, particularly resulting in pneumonia and septicemia. So the black necrotic skin lesions with an erythematous margin, these are called ecthyma gangrenosum. Very, very characteristic, and this is like just this is a keyword. It's very high yield. You need to remember this. Antibiotic resistance against Pseudomonas is a growing problem, and only a selection of antibiotics like aminoglycosides, the anti-Pseudomonal penicillins, which would be piperacillin, tazobactam, and azacitidine, carbapenem, ciprofloxacin, these are still effective against it. Some of the cephalosporins like cefepime and ceftazidime, these are active against Pseudomonas. Okay. Trimethoprim sulfamethoxazole, it's used for prevention of PCP and toxoplasma infection. It does not prevent Pseudomonas infections. Immunosuppressive therapy is given to transplant patients to prevent any rejection. If these medications were ineffective, the patient would present with evidence of worsening renal function, signs of rejection, but this patient has normal BU and creat, so you know that failure of immunosuppressive therapy is not the reason. And SCID is due to IL-2 deficiency, DiGeorge, and CGD. These are immunosuppressive disorders that present at a young age. It is unlikely that they present in a 61-year-old patient who is on immunosuppressive therapy. So I'm just going to quickly show you what these lesions look like. Okay, so it is most frequently described in the setting of bacteremia and immunocompromised patients. And it begins as a painless red macule, which evolves into an area of induration, develops pustules and bullae, and then they become these gangrenous ulcers. Yeah, so that's, just remember how it looks. That would be high yield for sure.
Thanks for watching. Please give a thumbs up and subscribe for more.